Live now. There's always a little lag on YouTube. So as soon as I see myself, I'll know we're live. Okay, we're live on Critical Care Now, doing the Critical Care Lounge. We're just going to vamp for a little bit, and then we'll do all the formalities and introductions why we are here on YouTube and what the heck we're doing. But on screen with me, I have Adam Green. What's up, Adam?
How you doing, Haney?
Good. How are you doing?
I'm good, man.
Awesome. Awesome. You excited for this?
I am. I guess maybe we should tell people a little bit about it, what we're doing here.
We definitely will. Let's give get
Give
people
everyone
a moment or two to kind of linger in. At Cooper we have Cooper time, where people come in at usually like
That's right.
30 past the hour. We're gonna get started way before that, but maybe we'll start up at 7:05. Hey Adam, we got people Austin, Texas. We have people Dayton, Ohio. We have Camden, New Jersey in the house. Shout out to Mike Bonk. And Guadalajara, Mexico. We're
Wow.
international. So there you go.
Look at that.
There you go. That's awesome. Someone else in Philly. Good day in Philly. Well, it's good to see you all. I know people will probably trickle in, but we'll get started in about 2 minutes. But yeah, let me know where you're from, so I'll give you all shout outs. Hugo is from Puerto Vallarta, Mexico. What's the weather like in Mexico right now, do you think? Do you reckon? In Fahrenheit though, I don't know Celsius too well. Hugo, let us know what the weather is, and for everyone else, we're gonna get started in about 2 minutes here. We're gonna let people dribble in. Mankato, Minnesota. Mankato, Minnesota is Kristen Clifford, all the way from Minnesota. Is it Central Time in Minnesota? Oh, and the chairman, Dr. Nathan Puri from
Oh,
Detroit.
wow. Oh, wow.
Bad boy town. Bad boy Pistons. Hugo says it's 100 degrees Fahrenheit. He humored me. He could have been, I'm not going to succumb to your American system, but he did. Almost 95% humidity. And Mark Kushel is in Oklahoma. And Mohammed Megheri, I know him, is in Huntington, West Virginia. And Kristen says, yes, by the way, if you were wondering, Minnesota is, in fact, Central Time. 1 more minute, folks, and then we're going to get started. And Fort Wayne, Indiana. More people will join, but we have about 24 people here. So we're excited to get started, and we'll tell you just why we're here. Raja is in Cooperstown. You know what's in Cooperstown, Adam?
Cooper?
No, I think it's the baseball.
I know,
Hall
it was a
of
joke.
Fame.
It was a bad joke. I was like
okay.
trying to make
That's the only thing I know
Hall of Fame,
about
yep.
baseball, is that Cooperstown has the Hall of Fame. All right, 7:05, Adam. I say we do this, and people, they'll catch up. They're smart enough. Well, my name is Haney Malamet. I'm joined by Adam Green. Both of us are intensive care physicians at Cooper Hospital in Camden, New Jersey. And we're really happy to introduce to you a new series that we will be doing consistently. We're going to be going for twice a month, and depending on how much you like it, maybe even more frequently. And the idea behind this Critical Care Lounge is to discuss the things in medicine that just aren't in the books. We like to call them the art of medicine, or the gray zones, and there's lots of things, including the topic that we'll talk about today. But there's a certain point you get to expertise where you just read everything you can, and then there's bedside practice. And we want to focus on the things that we do at the bedside, and that's the ethos of everything we're going to be doing. And the thought is this is going to be a laid-back, chill environment where everyone can come in, and please engage us in the chat. But we want to get experts here who tell us what they do so we can learn from them. Adam, do you want to talk a little bit more about the lounge and what we're talking about
Yeah,
today?
that's perfect, Haney. This is this has been a project that we've been brainstorming for quite some time, and I think the thought is, um, we've had the pleasure of working with and training all these fellows. They leave, they go off in their independent practice. They're sitting there, they have a question. They no longer maybe have all the partners, all their educators around them. You know, they're in Oklahoma at 2 a.m. and these topics are not up to date worthy. You're not going to get an answer. It's what should I do? And there may not be a right answer. And so we're hoping to create this hour of safe, protected time. No question is too dumb. No question is off limits, and we can just chat about what we do and how we approach things. And maybe we're wrong. Maybe you're right. Maybe it doesn't matter. And let's just kick back and you know talk some critical care.
Awesome. Awesome. Do you want to introduce our guests?
Yeah, so and I should say that each time we're gonna have two guests. We'll call them the experts. So I have the pleasure of introducing Dr. Dellinger, who professor of medicine. I don't know what can't I say about Dr. Dellinger. He's well published, amazing clinician, wonderful friend, great mentor, educator. I could go on and on. He's still the one I call whenever I have a question that I know no one else will know the answer to. So I'm just pleased that we get an hour of his time, and I'm upset we have to confine it to only one topic. I wish we could have him every week. And then I'll let you introduce Matt.
I have the pleasure of introducing Matt Shuba, who's an intensivist at the Cleveland Clinic. He's a senior editor for Critical Care Now, the website that you're on, but he's also just one of these guys who's just pure genius. Every time he writes about something, and you may have seen him on social media at Zentensivist, and if you haven't followed him, you definitely need to follow. So, gentlemen, thank you for being here with us tonight. And Adam's going to kick it off with a case, and then we're just going to get into some questions that Adam and I came up with regarding management for this specific patient.
So perfect. So the overall topic is going to be ARDS. And so I'm going to present a case. We're going to ask some very basic questions, have our two experts ping pong back and forth. And then maybe if time allows, we'll give some different iterations to the same case to see if management would change. So we're going to start with a 45-year-old male, comes in with hypoxic respiratory failure through the emergency room, gets intubated in the emergency room, diagnosis of bacterial pneumonia, ARDS. When you see him, on the ventilator, his FiO2 is 100%, his PEEP is 5, he's on low tidal volume lung protective ventilation, and his ABG comes out with a PO2 of 140. And the question is, to start, what are your first moves on the ventilator? What information are you looking for? What are you thinking about when you first see this patient?
Matt, you go first.
All right. First of all, it's an honor to be here. Thanks to Haney, Adam, and feel severely outclassed by Dr. Dellinger, but I'm happy to be here to talk through these cases. So I think in the first place, the thing that we need to consider is the diagnosis. And I know that sounds simplistic, but you're handed a diagnosis of pneumonia and ARDS, and it's important to confirm that. So first of all, I think you need to do the proper, in order to meet Berlin criteria for ARDS, you need to have demonstrated that this is not cardiogenic in origin. So that's step one. We're only on 5 a PEEP. So it's a little bit too early to tell for this person's more PEEP responsive than you'd expect from an ARDS patient. The second thing is the patient has pneumonia and they may have severe hypoxemia, but the distribution of the lung injury will have a large bearing on the way that we manage this case. Because if this is a really severe, dense unilateral pneumonia, we're going to treat it a lot differently than we treat something that was diffuse bilateral, typical ARDS. So I think those are the things that those are the sort of first thoughts that I have, because I don't want to assume the diagnosis I've been given is the correct one. So I'd like to do at least a limited echo and review the X-ray, review a lung ultrasound, and see if there's any competing diagnoses that I may be neglecting. And then from there, I think it's if you've confirmed the diagnosis, then I think you start down the path of typical ARDSnet ventilation, pretty much standard, following the original protocols as they were, and then we can talk about how we'd adapt them as we go through. But that's kind of my initial thoughts about how to enter this case.
So Matt, that was a very good setup. I mean, you did the things that people often don't do when they're on a panel, which is just jump right in and make a lot of assumptions. So it's great that you reminded people that you need to check all the boxes before you start treating ARDS. And so I'll just assume that all the things Matt mentioned, the boxes were checked, that this is bacterial pneumonia, ARDS. It does meet the criteria for moderately severe. It's in the range for moderate, between 100 and 200. ARDS, bilateral infiltrates. And the first thing I would do is make sure the pH is not a problem, because if the pH is a problem, then I'm going to turn to ventilation before oxygenation. So if pH is not a problem, then I'm going to move to ARDSnet. I'm not going to worry as much in the first short period about the 6 ml per kg tidal volume and the plateau pressure. I think the first thing I'm going to do is try to establish an optimum Peep in this patient. And I assume that Matt and I will address how we set Peep. Do you want me to go ahead and do that now?
Yeah, that'd be great. Tell
We
us.
might as well. We're here.
Yeah, so I tend to set Peep to driving pressure, and we'll talk more about driving pressure. So you can set it to driving pressure in a multitude of ways. You can do it just by using the ARDSnet low Peep or high Peep table. I think most would recommend the high Peep table for a PaO2 FiO2 ratio of 200 or less, which this patient qualifies for. That would be a starting point, or some people would just say, that's all I'm going to do. I think most of us would go beyond that and move Peep up and down, checking the driving pressure, which is with a fixed tidal volume, which we would be using with volume ventilation. You have to have volume ventilation to Peep set. And then you would find the lowest delta between plateau pressure and Peep as where you would want your Peep. And I'll stop there because I think we could, if we have time, we could talk about recruitment maneuvers, yes or no.
I just have one question before we leave driving pressures, because I see this information all over the place. How long do you wait before you make your Peep change, before you reassess, assuming that there's going to, I see some people doing 30 seconds. That's probably way too long. People just want to get in and out of the room. But how long is an adequate time between your Peep changes to know you're truly measuring that compliance?
I haven't seen any good evidence-based medicine on that. I think that when you look at prospective research studies, they tend to use 10 minutes. I think that's impractical in a critically ill patient at the bedside that you're not publishing. I don't think you need 10 minutes. Clearly, you can continue to recruit over a period of time, and I think 10 minutes is what's sort of used in a research setting. I think for practical purposes, probably 3 minutes.
Perfect.
But it also depends on, we've got the luxury here of having a PaO2 of 140. So other than using up your time, it's not a patient problem.
Perfect. Matt,
You,
do you want to
can I ask a quick question? Also, Matt, you mentioned making sure ventilation's okay. What pH are you targeting? I think that there's difference of opinion.
Well, I think that I feel comfortable with anything 7.25 or greater. The tidal volume right now might be significantly higher than 6. So as you lower the tidal volume, whatever your baseline is, is going to go down, and then you'll have to compensate for that with rate.
Matt, you have anything to add?
Yeah, so fortunately, we're on the same page, I think, pretty much all the way through there. But a couple things that I'll emphasize. I'm absolutely a driving pressure person. I think it just makes obviously the data that we have to support it is observational in nature and mostly retrospective. But there's enough rigorous, high quality observational studies to suggest that it's a smart target. So I do similar to what Dr. Dellinger does. I think the starting off. Where do you start with Peep? I think you want to start on the Peep table. That's fine, because I think the benefit of starting with a high Peep table, let's say, for instance, is you're probably not going to undershoot. And I think a lot of people tend to undershoot. But then I agree that I would make incremental changes upward and downward to see if I can optimize the driving pressure. And generally speaking, lower is better. Certainly the inflection point for mortality is at 15. So less than that is better. And the lower even better than that. So in that way, I agree. There was actually a nice paper a couple years ago in respiratory care. Serena Sahetya from Hopkins is the first author on it, and she did prospective observational titration of driving pressure and see how long it took the driving pressure to stabilize. And the numbers that they came up with were between 1 and 5 minutes. So I think that 3 minute range that Dr. Dellinger quoted is right on. And I think generally speaking, I'm kind of impatient, so I'm probably around the 1 minute mark, but a couple minutes at least. I don't necessarily expect to see oxygenation changes as quickly as I see driving pressure changes. So that's something that we kind of have to be a little bit more patient about. Some changes you'll see quickly, others as things recruit, it might take some more time. But I'm 100% in the camp of driving pressure for PEEP titration. And that's just a place to start. And if you can't optimize it by that, then you can start talking about, should I be modifying the tidal volume lower if this person doesn't have a lot of viable parenchyma that's aerated or participating in gas exchange. The pH question is an important one and still a little bit hard to precisely define. I think I generally am like a 720 person. Now, is that much different than 725? I don't know if it's big enough to advocate for one over the other. The thing that I will say though is, what are the consequences of worsening acidosis? And I'm not talking about like vasopressor response or anything like that, because I really don't think that's relevant. What I'm talking about more is this going to start to impact right ventricular performance, and is my pulmonary vascular resistance going to rise to the point where I'm going to cause acute cor pulmonale or frank RV failure? So those are the things that I worry about in terms of pH. And so if you see like hemodynamics are worsening as the pH is lowering, then I think it's time to look at the RV and make sure that we didn't start to impair its function based on our settings.
Perfect. Thank you. I guess let's move on to the next question. That was really good. When and maybe we'll just do it combined. When do you think about next steps? Paralyzing, proning the patient. Are they one and the same? Do they need to be paralyzed to be proned? What's your sequential order in terms of, let's say the PF is now 90? How do you approach it?
So I think it's important to recognize that evidence-based medicine supports proning much more strongly than paralyzing. In fact, after the one study with the continuous infusion cis atracurium that showed improved outcome when given for 48 hours and got everybody talking about patient respiratory effort induced lung injury. And I think a lot of people got on the bandwagon of continuous infusion cis atracurium. It wasn't overwhelming, but the Rose trial by the Pedal Network did not show any benefit of continuous infusion of paralytics during the early ventilator management of ARDS. So I think currently that's sort of off the table. One of the differences in the Rose trial was that high Peep, the high Peep table was used. And it may be that the benefit from the trial that used continuous infusion was they used the arginate low Peep table. Even has some people saying, well, if you're going to use continuous paralysis, you probably should use the low Peep table, because that was what had a good outcome. But so I don't use paralysis except in that initial sweat box by the bedside when a patient's trying to die from ARDS hypoxemia. I don't hesitate to use it then, because I found anecdotally that if you take away the patient's effort, often I do see an improvement in oxygenation. But my plan would be to get them off of it after I get the ventilator set up. And I use it if I still have a very desynchronous patient after sedation. If I can control the synchrony with sedation, that's optimum. And I'll stop there and let Matt comment.
Yeah, Matt, I'm gonna, for the sake of time, I'm gonna challenge you specifically about paralyzing, what you're targeting, this new phenomenon of weaning the paralytic, which I've never heard before, and what's your approach? How do you use Nimbex?
Yeah, that's a great question. I want to echo everything that Dr. Dellinger said in terms of where we are with the evidence. So I think that the cases in which paralytics should be favored is if you have severe hypoxemia coupled. So let's say, P to F less than probably 100, coupled with dangerous dysynchrony. And there's a couple of things that need to be sort of clarified here that I think are important. Depth of sedation. There's a nice paper that just came out in CCM this year, I think in the last month or two, showing that there's often a discordance between depth of sedation and respiratory drive. So I wouldn't necessarily think, it's good. I think it's always a good first strategy to try deeper sedation if you have synchrony issues that can't be ameliorated by making vent changes. But don't assume that, sometimes what happens when I have trainees with me is they'll say, oh, we deeply sedated them, so now everything should be fine. We still have to go back and look at the ventilator and see if that deeper sedation actually had the impact that you hoped it did. Because if dangerous dysynchrony is still a problem, then I think you need to move towards at least a short-term paralytic strategy. And I think that would be something that could be as short as I give a push and I optimize my settings and I let them wake up and see how they do. Or it could be I'm going to do it for 6 hours, 12 hours, some short period of time. There's no reason to obligate to 48 hours based on the evidence that we have now. Two particular cases that I would say I favor paralytics more than others is if I feel like I need to use less than 6 cc's per kg tidal volume. Let's just say their lungs are still really poorly compliant and I have very little viable lung I'm working with. If I'm going for 4.5 or 4 or 5 cc per kg tidal volume, sometimes that's a little harder for patients to tolerate. So that's one instance. The other instance is if they have horrible ARDS and they have severe circulatory shock and you're trying to decrease oxygen consumption, I feel like that's a viable strategy there, but also still for the shortest period of time possible, and just to achieve some sort of hemodynamic endpoint. But it's not something where you just set it and forget it and walk away.
Perfect. Haney, do you have anything to add or?
No, that's great. I think just to bring it all together, I think what we're saying is that there's agreement in the fact that there's no set paralytic. It's not 2 days and then come back and check. It's use it to get yourself optimized, to get the patient out of the rut they're in, get them settled down, and then come back and try again. Try to keep the patients as unparalyzed as possible. And then I want to go back to Dr. D's point about proning, because that's something that there's great benefit for and great evidence for, but then there's some nuances of proning. For example, some of the questions that I'll have, and we don't have to answer in this order or all of them, but what's your PF? Do you prone a little earlier, like less than 200? Are you proning for 16.8? When do you get a gas? What's your? I just want to pick your brain and see with proning, which is such a great therapy. There's a lot of variations in what people are practicing. So I'm just curious to hear everyone's thoughts. Maybe we'll go to Dr. D first.
Yeah, so my practice is to prone if after setting the Peep, getting optimum Peep, I still have a PaO2 FiO2 ratio of equal to or less than 200. That's my threshold for proning. I think it should be recognized that, we've known for a long time that proning improves oxygenation, no question, sort of like steroids and decreasing vasopressors. But there's only one trial that's shown outcome benefit, and it was a very good trial, the ProSiva trial, and they enrolled patients with the 150 threshold instead of a 200. But the fact that 150 showed outcome benefit and so many trials of our subgroup analyses and studies of 200 showed a significant physiologic benefit, I use 200 threshold for proning.
Matt, is that the same duration too, or the same cutoff? Or are you going
Yeah,
for 150?
I'm typically doing 150, though I definitely see the rationale for 200. Some of it is going to depend on what it is going to require of the patient and the care team. To get back to something that you asked earlier, is does a prone patient need to be paralyzed? And I think the answer to that is not necessarily, but I will say that's often what happens. So if that's coming into the if that comes into the calculus, you say I need to paralyze this patient so I could prone them, then I'd be a little bit more hesitant unless I'm meeting ProSiva inclusion criteria. And then duration, I think 16-ish hours just based on the median duration and ProSiva makes sense. Going longer is fine. Going shorter, it's hard to say if there's still as strong of a benefit. You just have to allow enough time for the patient to be flipped over to make sure they're not developing pressure injuries and for the nurses to be able to do general care for the patient. But I think aiming around 16 hours and pushing it a little bit further at times is reasonable. The other thing is, just think logistically when this is going to happen. If you prone somebody and they need to be supinated at 4 a.m. when you have a skeleton crew, maybe you wait the extra 3 or 4 hours and wait till you have enough people around to do it safely. But I'm absolutely proning as much as one could be, just based on what we know about it in terms of its benefits. Not only the hard benefits of mortality benefit, but also soft benefits in terms of redistribution of lung stress and strain, and maybe improvement in some other hemodynamic parameters.
Great. Yeah, something that's always bothered me about having set PF for proning is that there's no control over Peep, right? We're assuming that the PEEP has been optimized, but I've always been curious at that. I have a hard time. I think we all do this as we look at the X-ray, we think about physiologically if there's a benefit, and I think I'm much more prone to push someone who I think is going to have improvement, even if their PF may be 160 or 201, right? The other thing I had is how many prone sessions do you do? I see it all the time. I think it's kind of funny. The patient who gets proned and then doesn't improve gets proned 6 more times, but the patient who gets proned and improves a ton doesn't get proned again. Maybe it should be the opposite, right? The patient who's responding and PF got better, maybe they should get 8 hours on their back and get flipped again for 16, even if their PF is over 200. I don't know if either of you have thoughts on that.
Well, I think proning makes a difference through improving compliance, not through improving oxygenation. I think just based on what proning does, which is opens up dependent lung more so than supine, and decreases overinflation of non-dependent lung, and I think that leads to less ventilator-induced lung injury. So you prone patients to improve compliance. Now, if someone's dying from hypoxemia, then proning becomes not only something to decrease ventilator-induced lung injury, but something maybe to keep the patient alive by getting the PaO2 up to acceptable range. But that's not usually the case. So to me, it's all about compliance. And the improvement in oxygenation we've learned from the very first ARDSNet trial. The group that did worse, the larger tidal volume, first few days had significantly greater improvement in oxygenation. And I as the lead investigator for the two North American inhaled nitric oxide trial, we showed clearly that improving oxygenation doesn't make any difference necessarily. So I look at it, to me, it's all about compliance. And if when I prone, I see a clinically significant improvement in compliance, that's an incentive for me to stick with it.
Yeah, I was hoping you'd say that. Oh, sorry, Matt. You go first. You go first.
Yeah, no, that's all right. So I largely agree. I wouldn't use oxygenation improvement as a marker of whether this is a successful therapy or not. I think deciding to reprone people at a minimum based on the ProSiva criteria, which I think are if your PDEF was still less than 150 with a FiO2 of 60 or more and a PEEP of at least 10. I think that's a good starting place to say maybe I should reprone this person, because in that trial, the median number of sessions of proning was 4, but I think it was like plus or minus 4 for the range. So that is, I think that's a good place to start. But I agree that lung mechanics benefits over gas exchange benefits is probably a reasonable place to decide whether this is helping or not. Because when this has been even studied observationally, the oxygenation response doesn't actually correlate even in proning with improved mortality.
Just a quick question. It's a question from the audience. Since we're talking about moving patients around, someone was asking, actually, I'll give him a shout out. Abdul Jabbar was asking, proning is good, but if you know based on your CT or X-ray that there's one side of the lung that's more consolidated, does that change things for you in terms of positioning?
I would say, go ahead.
No, Matt, go ahead.
Okay, I was just going to say, I think it's reasonable. The physiology makes sense. Say, put the good lung down. Hopefully, you improve the VQ matching. I will try, if it's really truly severe dense unilateral disease, I will try it. Mostly because it's less intense resource wise and manpower wise to do that. I'm not sure how often I've done it enough that I can say I've had times where it helps, but I have no idea how frequently it is. And I think if it was insufficiently helpful, I would still consider a proning trial if they were severely hypoxemic.
Yeah, I sort of look at it like the PA catheter hemodynamic profile. It's one of the most powerful teaching tools that I've ever seen at the bedside. And same thing for teaching physiology and pathophysiology when you put the good lung down. But in my experience, it rarely ever produces a clinically significant improvement. Whereas if you think about predominantly unilateral ARDS, you're still going to try PEEP titration, even though it may make things better, it may make things worse, or it may have no effect. And that's sort of the same thing with proning. I might have a little lower threshold for proning because I put that in the bucket of maybe this is less likely to be as big a success, but you're still going to be putting that lung, you're still going to be proning that one lung. So it to me, it makes sense.
That's great. Let me just, because I want to keep these discussions really succinct, although to be selfish, I really would like to keep you both here on all night long and just pick your brains because it's tremendously helpful and everything's been gold so far. But Scott Long is asking from the audience, would you recommend an ECMO center to start considering transfer for an ARDS patient? So my question is essentially a modification. Is like, when in your algorithm, because if you're not in an ECMO center, right? So when do you start to say, at what point do you say, I think this is failing? At what point do you just say, this is refractory enough that I have to get on the phone and start making arrangements to transfer?
Actually, Adam could answer that better than me because he's part of our ECMO group because we are a referral center. I would just say that as a general rule, ECMO centers tend to also be great at all aspects of treating the most severe ARDS patients. I think the Caesar trial showed that. So I would encourage, as long as your patient you think can be safely transferred, to have a threshold that's more on the higher than lower. Certainly persistent PaO2 FiO2 ratio less than 100 would be a reason, but I'm sure there are published data on that.
So then let me just ask the question. It could be really be to anybody. If you're working in a small center and you've prone the patient and you're not getting improvements, and again, there's no right answer here, but I'm sure there are people here who work in small centers like, I just don't know when to make the phone call. Is it after paralytics? Is it after I do 2 or 3 sessions? What would be your practice if you're working at a small limited resource hospital?
So
Matt?
I don't know, Matt, if you want to take this, or if you want me to go, whatever
Sure.
you want.
I'll go quickly and then you go, since you're receiving a lot of these. So my perspective is unique in that I spend 70% of my time in a tertiary referral center, and then I spend the rest in a well-functioning but essentially community hospital without ECMO capabilities. So I have a little bit of perspective from both sides of the fence on this, but I think in general you should do all of the basic things right first. So sometimes people will call for ECMO transfer and the patient's on a 10 cc per kg tidal volume and a PEEP of 8 and 100%. And I don't know anything about, this patient hasn't even had an attempt at being optimized yet. Now, if it's a center that doesn't feel comfortable taking care of complex patients, that patient may need to leave. The threshold for sending that patient may need to be lower. But I think one of the sort of perverse benefits of the pandemic is a lot of people got experience taking care of sicker ARDS patients. So I think on some level, we're obligated to do the right things first. So low tidal volume ventilation, PEEP optimized, at least a trial of proning, and then and plus or minus paralytics. And I think if you're not experienced taking care of ARDS patients, then maybe you should be a little bit sooner to engage paralytics just to be able to ensure safety. I think if you've done all those things and you're still having, I think certainly the P to F ratio less than 100 is a good cutoff. That person probably needs to be transferred. If there's extenuating circumstances that are unique, like a really bad dense unilateral pneumonia, you just can't improve the oxygenation, that might be somebody who needs to come sooner. I think making a phone call is never a bad idea, but I would also still make sure that you did the basic things right first.
Fantastic.
Yeah.
Thanks. What do you think, Adam?
Yeah, so I think it's so interesting, and we can all go on ELSO, and we can all read Perceiva, or Caesar trial. We can all look at what the criteria are and who does better on ECMO and who doesn't. But that's not really the point of, I don't think, of this talk. And I will say the things I think about when I'm receiving the phone call is I would prefer you to call me early rather than late. So the patient who's on day 6 and they must be cannulated before day 7, that's not a good time to make the phone call. There's the patient who's on the borderline and you put them in the van to ship them to us. And if they weren't an ECMO candidate at your institution, they become one as they de-recruit for that hour trip. So I think the time to call is that young, single organ, rapidly deteriorating patient. Those are the ones that really benefit from lung rest from ECMO. It's not the patient who has this indolent, they're 59 years old. They don't have any comorbidities. They click all the boxes, but it's this slow progressive, and now they're at day 7 and their PF is, right on the borderline. That's not necessarily the best patient to call. That's a patient I may say, paralyzed, keep proning, like fight the battle. I'm not sure ECMO is going to help. And not to totally get into it, but yes, it matters if they're COVID or not COVID. It does matter that it's 2 definitely different flavors of ARDS with 2 different survival stats on ECMO. So I don't know if that helps to bring some clarity. So think about, calling early rather than later. Think about the speed at which they're declining, and think about the risks of transport. Because even on the ventilator, even prone, they're real and can really change things.
Well, that's fantastic. I think if everyone's okay with it, unless anyone had anything else to say, I'd like to just turn over to the audience to answer some questions that are in here. Is that all right? Does anyone have any other points? Dr. D? Matt?
No, I would only add to what Matt. I agree with what Matt said about need for paralysis in proning patients. The paralytic days, mean and standard deviation, were very similar in both groups in the ProSiva trial. I could have picked up the phone and called one of those investigators, as Matt could. They didn't report the numbers that received paralytics, just the mean standard deviation of days, but they're very similar.
Perfect. All right, so I'm going to dig into the chat here. There have been a lot of questions, and I want to acknowledge everyone and thank everyone.
I'm sorry. I said ProSiva, but as far as days of paralytics, it was a ProSiva trial, and I think it was like 5.6 days plus minus standard deviation.
Great. Again, I thank everyone for the comments. It's like people ask the questions and then automatically you knew they were saying it. So a lot of the questions got answered, but I'll point out the ones that didn't get answered that are pertinent. And one of the questions that someone was asking is, if you're deeply going to sedate somebody, and I think this overlaps into COVID, what sedatives are you using in your patients that are really difficult to control? And this is for anyone.
I think I don't know how much my practice has necessarily changed in terms of sedative management. I will say we've probably employed a little bit more combination therapy than was done prior, and I don't know if that was just because of surge or if that was really truly what the patients needed. I know everyone feels that these patients are harder to sedate, and I think in some ways that's probably true. But some of it I think is just the way that we manage the ventilator, but that's a conversation for another day. One thing I'll say is I probably have used more adjunctive ketamine on top of the typical propofol fentanyl combination. And I think that's for depth of sedation, especially if you're considering trying to facilitate neuromuscular blockade. Important to know though, because this is something that I see often, is people will add on ketamine or they'll add on dexmedetomidine as an adjunctive agent when they're trying to manage work of breathing. And those medicines will not affect respiratory drive. So it doesn't really make sense to use them for that purpose. But if you are trying to, have an amnestic effect, that's the time to use ketamine or a similar adjunctive agent on top of what you might usually use.
And Matt, since you mentioned it, what's your go-to ketamine dosing? Because the literature is kind of all over the place on that. I like it and I use it, but I'm curious.
For as an adjunct, it's probably going to be somewhere in the 1 to 3 mg per kg per hour range. But all titrated to effect, so somewhere in that range generally. Our dosing interestingly, our dosing range starts really small. Like I think it's just because people weren't used to using it for this purpose, but our dosing range starts at like 0.3, which is like subdissociative dosing you might use for pain, which I don't think I would probably use as an adjunct sedative. So it does require, just like every other medicine we use, it requires comfort with what range, what effect should I expect at what ranges.
Great.
Haney, critical care medicine is likely to be publishing a very large group of patients from an observational study with multiple hospitals and a large hospital group with ketamine that will allow people to see what dose ranges are used and what adverse events are associated with them. I think that'll be very helpful because it is all over the place. I used tenfold more ketamine with the COVID surge than I had ever used in the unit, and went back to regular use of benzodiazepines for the first time in probably about 10 years.
Fantastic. All right, let's get a couple more questions because we're getting just about time. So maybe we'll just do some quick short fire burst yes/no questions. Someone is wondering why I'm trying to look like Matt Shuba by dressing up like you, and that's just because I admire you so much.
We coordinated.
All right, so I'm just going to, again, put it out to you, just say yes or no or as succinct as you can. epoprostenol, inhaled nitric oxide. In your practice, if you have access to both, any real difference between them?
I think the evidence would say that there's not really much of. I mean, I think EPO is probably at least non-inferior to nitric oxide. Now, is it worth using either of them? Is really probably the more important question. The bigger thing is, okay, it's just like I think Dr. Dellinger mentioned before, improves oxygenation, not improving any hard outcomes. So the time that I would use it is if I have somebody that's not an ECMO candidate and they have really severe hypoxemia that I think is going to cause organ damage, I may consider it, though that person also needs a goals of care discussion if they've not already had one. The second case is if your RV hemodynamics are in trouble, you may use it to try to decrease your PVR, though I will say that's more of a physiologic concept than something that actually, I think it helps sometimes, but not as much as I would like it to. But beyond that, I think it is still grossly overused, and it usually creates a barrier to some other care that has probably higher efficacy, whether that be prone positioning or ECLS.
Fair enough.
Yeah, I'll only add that often it gets instituted very early on when a lot of things are being done simultaneously and there's no scientific approach taken to once you can do just the inhaled selective vasodilator and not manipulate anything else to show that it's not making any difference and stop it.
Great. Okay. Next question. I'll just pose it to both of you, and then I'll ask you a next question following that. Steroids, yes or no?
Yeah, I use them now based on the VR trial I think it's 10 milligrams and then 5 milligrams of dexamethasone. And I don't even remember the days, but Matt may remember. And I think the recovery study would indicate that for hospitalized COVID, which would include ARDS, although only about 1 in 6 patients in that study was on the ventilator, that a 6 milligram dose for a shorter period of time would be appropriate.
Matt?
Similarly, I like the DEXA ARDS study. I think I still think it's gonna take us some time as a community to decide if this is something that we're gonna do. For me, I'm in favor of it, especially if somebody has severe, PDAF less than 150. I'll do the DEXA ARDS 20 for 5, 10 for 5. But usually if they're rapidly improving, I'll back off before then. Similarly, obviously I use dexamethasone in COVID patients, though I tend to also still favor the DEXA ARDS dosing range rather than the recovery, because recovery is like 6 is like 40 of prednisone, which we give to people when they have the sniffles. It just doesn't seem like it's probably sufficient. The other thing, though, is there's a Brazilian trial called Codex, which used the ARDS, DEXA ARDS dosing. And so that is, and it did not have a mortality benefit, but I think duration of mechanical ventilation was improved. And so I still favor that 20 for 5 and 10 for 5. But the key to all this is if you're not on service for 10 days in a row, the person that comes after you may change your plan. So it's all about having some consistency and culture amongst your partners.
Yeah, Haney, I need to sort of counter that. I think that there's data of steroids in influenzal ARDS that's bothersome. And I think to me, when I use 6 milligrams for 10 days in COVID, I feel like that dose was shown in viral ARDS, even though it's a small subset, to suggest benefit, whereas I'm still got a lot of that data from the H1N1 that makes me concerned about higher dose steroids. So that's why I use 6 for 10 in the COVID patients, and then the 10 and 5, 20 and 10 for 5 and 5 for the standard ARDS.
For non-COVID. Okay. So if someone comes in, they're COVID, they're not intubated, and then they develop ARDS, you're keeping them on the 6 for the duration.
I would.
Yep. Gotcha. All right. Then the last question I'll ask you about steroids is if you have a patient that at the end of your steroid period is still not improving or getting worse, do you employ more steroids at that point, or you believe that the steroids have run their course, they're out of the inflammatory period? What are your thoughts on that?
I think you're in no man's land. And Haney, as you know, there was a tendency to want to keep giving them and labeling the patient as maybe having fibroproliferative ARDS because there was this thing floating around about COVID ARDS seemed to be producing more fibrosis, and these patients just were absolutely not moving. I mean, they were just bad, staying bad. So you look for a reason to continue to use steroids, and that was your out, the fibroproliferative ARDS, although you need to remember that the Lazarus trial did not show an outcome benefit.
So we're just treating ourselves basically than the patient.
Likely.
Matt, any other thoughts on that?
No, I think it's a really murky area. My disclaimer is I only take care of patients in the confines of the ICU, so I don't have to think about it beyond that. But I don't generally extend past 10 days, especially if they're generally that by that point their inflammatory markers have come down or normalized. I'm just not sure what endpoint I'm trying to achieve, other than try to feel like I'm doing something, which is not a great reason to do anything.
Perfect. Adam, any thoughts?
No, that's great. I think there is a small set of patients that we see that steroids get stopped and they, 24 hours later, they become febrile and have new infiltrates, and a very small set that almost rebound, in which case I may be prone to reinstitute steroids to see if there's a benefit. And I totally agree with you, Matt. I find my steroid dosing is usually based on whatever the intensivist was before me. I like making decisions and sticking to them. So, if someone had chosen Dex ARDS, I usually continue as opposed to changing the regimen every time there's a new attending, because I don't know if we have enough information. I do know there seemed to be enough concern about bacterial superimposed infection, because I think we just want to believe, and I think we've had enough studies that have debunked that myth. I think it's safe to give steroids in these doses and not worry about superimposed bacterial infection. I did, if you're okay with it too, I do see there's two questions that I think are regarding ECMO. One asking about uncompensated hypercapnia with a PF over 100, and another asking about how COVID is different. And both of which I'm going to choose to intentionally not answer and give a little plug for our next session in 2 weeks, which is going to be all about ECMO. And so I promise both those questions will be answered in 2 weeks. Unless either of you have a burning desire to talk about it, I think we can save that.
No, I like the teaser.
Good. Perfect.
Dr. D, Matt, any closing thoughts? I'll tell you just right off the bat that tremendously honored to have both of you on here for the inaugural Critical Care Lounge. And this has turned out to be exactly what we wanted. Differences in opinions, people not agreeing exactly, and just hearing your practices was tremendously helpful for me, and I learned a ton. But to you both, any closing thoughts, Dr. D?
No, I would just say that since I'm muddled through the doses, I need to make sure everyone's clear that the DEXA ARDS dose is 20 times 5 days and 10 times 5 days. And from the recovery trial for hospitalized COVID, it's DEX 6 times 10 days, either IV or PO in both circumstances. And the Lazarus trial, which was the big ARGNet trial of high dose sustained steroids for fibroproliferative ARDS, there was no evidence that it triggered clinically significant infection, which supports what Adam said. And it's been a pleasure being here with Matt, and I thank you and Haney and Adam for hosting it.
Thank you so much. Really grateful. Adam just dropped off for a second. Bring him back on. Great, there he is. Matt, any closing thoughts?
I want to echo what Dr. Dellinger said. I was honored to be here and speak with you all and talk about these things that I'm really passionate about. I love these kind of conversations because we kind of talk about what we do in the gray zones or on the margins. But in order to be able to have those conversations, you have to do the basic things right first, and then you can start to, freestyle if somebody's not responding appropriately. So make sure you're hitting your tidal volumes, optimizing your Peep, proning people, and then we can talk about where we go from there.
I do have one last real quick one.
Yeah,
so we talked about driving pressure for Peep setting, but the recent data would support that driving pressure is probably also very important for setting tidal volume. So if you can increase your tidal volume and not change your driving pressure, then that probably is something that's okay to do, because it's more about driving pressure than tidal volume for influencing outcome.
Totally agree.
And for people that want to know that reference, Dr. D, do you have the paper handy off the top of your mind? If not, we can send it out later.
Um,
I reviewed it for us.
I think it's out of a Toronto group were the main ones, and Gallagher was a co-author, and it's very recent, and it led to a Tobin letter about, I've been telling you this all the time, stuff that really wasn't true, but so much for that.
So Haney, as a plug for our site, I reviewed that paper, I think back in January. It's the post is called "Can we personalize beyond 6 mLs per kg? Can we personalize lung protective ventilation?" And it reviews that Ewan Gallagher paper that was, I think, was in the Blue Journal about elastance, using elastance to as a target. So, but yeah, it's a great paper, and I think it in some ways changed the way I practice.
Well, we've checked all the boxes. We've gotten final thoughts. We talked about recent literature, and we plugged critical care now. I really don't think there's anything else to say at this point.
Go Eagles.
Go Eagles. That's right.
There we go.
We need a W this year. Matt, Dr. D, thank you so much for being on. We really, really appreciate it. Have a great night.
Thanks, everyone.
So there you go, Adam. First one. How do you think it went?
I liked it. What do you think?
Yeah, I think it was really good. The chat's been blowing up. Please drop us a line in the chat. Really curious to hear what you thought about it. But for me, selfishly, this is exactly what I hoped it would be. A roundtable discussion of just people saying what they do. And, there's some evidence, but there's some experience, some eminence at the bedside. And I can really appreciate that. So please drop in any comments. Mike Bonk says, "Go Birds." So some Philly fans in there, and someone wants us to do more time next time. But everyone's very grateful in the chat, and I thank all of you for being in the audience tonight and tuning in. Any final thoughts there, Adam?
One thing too, if there's any questions we missed, we're sorry. That's not our intent. Sometimes things are happening fast and we just don't see it. So please feel free. Keep rewriting them. Keep posting. The point is to give you guys what you guys want, not for us to sit up here and talk. So I loved it. I hope everyone else enjoyed it.
And as Adam said, we're going to be coming back in 2 weeks. We'll start posting tomorrow, the day after. We're going to start advertising. Next is going to be talking about ECMO for respiratory failure, or VV ECMO. So tune in for that. You'll get some more information. So with that, I wish you all a safe, pleasant evening, and we will see you in 2 weeks.
Absolutely.
All right. Have a good night from the Critical Care Lounge.